My name is Darren Kies. I am the Section Chief of Interventional Radiology for Piedmont South Imaging. So a portal vein embolization is a procedure that's done by interventional radiologists to try to grow the what's called the liver remnant, the part of the liver that will be left behind when planning for a major hepatic resection. It relates to the treatment of liver tumors in that, again, it's designed to grow the liver remnant. When a patient has either a primary or a secondary liver cancer that is amenable to surgical therapy, let's say, for example, a right hepatic resection or right lobectomy. A lot of patients, what's known as the liver remnant, which is the remaining left side of the liver that would be left behind in this example, they don't have enough liver volume to survive on. A normal healthy adult who's never had chemotherapy and has no evidence of chronic liver disease needs about 20% of a liver remnant. So the way this is determined is you use cross-sectional imaging to determine what the total volume of the liver is. And then it's just simple math. You determine what the volume of the right hepatic lobe is and the left hepatic lobe. And if the left hepatic lobe reflects 20%, at least 20% of the volume of the liver, then you don't necessarily have to have a portal vein embolization prior to hepatic resection. But there are a lot of patients where that's not the case. Furthermore, with regards to oncology patients, a lot of patients have had upfront chemotherapy, or there are a lot of patients running around that have steatohepatitis, or just have chronic liver disease from hepatitis C, or just cirrhosis for some other reason. Those patients need at least 40% of a functional liver remnant to survive after hepatic resection. So in those cases, what you can do is you can, through the skin, you get percutaneous access into the portal vein, and you use different types of materials to occlude the right portal vein, and you leave flow remaining into the left portal vein. This effectively cuts off about 75% of the blood flow to the liver. The remaining 25% comes through the hepatic artery, and it induces shrinkage of the treated lobe. So that lobe will shrink down in size, and more importantly, the other lobe, it also induces hypertrophy of the contralateral lobe, and it will grow significantly in size. This process takes about 4 weeks to work, but once performed, you repeat imaging about 4 weeks later, and if the patient's liver has hypertrophied, the contralateral liver has hypertrophied to a degree that they can then undergo hepatic resection. It can be a very useful tool to help stage hepatic resections.